So what we're going to do now is I'm going to have Dr. Vicki Hoverman come up and do the presentation of our winning scientific awards, or scientific abstracts. Vicki, take it away.
Sorry, a little shorter down here. Can you hear me? All right, thank you all for being here today. If Mr. Smith and Dr. Van Horn could come to the side of the stage, that would be great. So my name is Vicki Haverman. I'm the co-chair of the scientific committee for the International Conference on Stigma. I was working with a great team to select scientific research to bring to you all today in the form of poster presentations. We had a lot of excellent abstracts submitted. It was a really tough choice. I'm going to introduce the best scientific abstract winner and our second place scientific abstract winner. They have fantastic research. So if you will join me in giving a warm welcome to Mr. Blaine Smith and Dr. Struthers Van Horne. You guys can go ahead as well. I'm going to introduce you guys first. So if you want, yes, please. Sorry, I think they're making their way up. Oh, no, it's okay. Yeah, thank you. All right, so I'm going to introduce both our speakers and then let them come up one at a time to share with you. The recipient for the Best Scientific Abstract Award was Mr. Blaine Smith. He's a research specialist at the Whitman Walker Health, where he primarily works on a NIDA-funded minority youth sexual health study, as well as other qualitative sexual health research projects. Mr. Smith's work engages an intersectional framework to understand gender, sexuality, class, and health in urban contexts. He received his BA in sociology and political science from American University and plans to pursue a PhD in sociology, woohoo, in the near future. Mr. Smith is now he's going to be presenting his research first, but first I'm going to also introduce our second place scientific abstract award was from Dr. Struthers Van Horne. She's a research statistician for the Bureau for Labor Statistics, where she conducts research in behavioral sciences and survey methodology. Dr. Van Horne earned her master's degree in sociology from Minnesota State University, where she wrote her thesis on how closeness to those with mental illness impacts stigmatization. She received her PhD in sociology from Kent State University, integrating structural stigma into the mental illness literature for her dissertation work. And so I will first welcome up, if you can give a warm welcome to Mr. Blaine Smith. He's going to present his research on youth perceptions of stigma towards an LGBTQ youth wellness model.
Hi, everyone. I am really excited to be here, and I thank the conference for welcoming this research. I'll tell you a little bit about it. So this research is based off of 5 focus groups that were conducted with LGBT youth in the fall of 2015 through Whitman Walker Health, sponsored by the Washington AIDS Partnership Fund. And 44 youth participated between the ages of 16 and 24, broadly across the category that we call LGBTQ. Basically, our goal was to find out what wellness meant to these youth and how the adults and the providers in their lives could enhance that wellness, what barriers existed to being well for them already, and how they perceived stigma, what kind of stigma looked like in their lives. So I'll talk a little bit about that. So a big part of stigma for LGBTQ youth is basically feeling isolation and invisibility. So in the materials that they're given to learn about their bodies, relationships, sex, media, and every domain of their lives, they're not seeing people who look like them. And at this really formative stage of identity formation, that can be really challenging and creates a lot of additional stressors. In addition, as we've heard people talk about today, sex between youth is already stigmatized. There's this idea that if youth are looking for sexual health materials, if they're going for reproductive services, if they're going for sexual health services testing, things like this, that they're already doing something wrong. And the additional layer of being sexual and gender minority, it really creates a barrier to sort of seeking those services, seeking information, getting the opportunity to learn about yourself, about your body, about the kind of sex that you might not even be having yet. Further, they really sort of reflected on how like queer, inclusive health and wellness information should be for everyone, not just for LGBTQ youth, because the absence and the secrecy of LGBT bodies and of LGBT sex in sexual education materials in schools, in materials that you might find in providers' offices, different domains like this, that creates like a level of secrecy that perpetuates stigma. So basically, we asked youth to talk a little bit about how the stigma that they experienced impacted their clinical experiences. And a big part of that is that if youth feel, or if they feel stigmatized, or if they anticipate judgment, if they anticipate a stigmatizing experience, they're a lot less likely to share with providers, and they might not request needed services, especially those related to mental health and sexual health. They have a lot of guilt about queer sexual behaviors, and sort of this feeling of being in the exam room and having to confess your sexuality to your doctor is an additional layer of challenge that other non-LGBT youth don't experience when they're trying to receive sexual health services. There's also just sort of the pervasive adultism in care, so this idea that adults have power over youth, that it's their job to tell youth what's wrong with them and how to fix it, and that the accompanying prejudices that youth don't know what's best for them, they don't understand their bodies, they don't understand their needs, create a really intense barrier to self-advocacy, especially in clinical care. Additionally, a really important part of this was youth really pushed back on sort of the risk assessment and reduction paradigm, as sort of stigmatizing. So youth didn't want to be seen as high risk. They felt like once they came out as LGBT at a provider's office, that their care began revolving around their sexual health, even when they might have many needs, even when they might not necessarily be having sex or might not be having risky sex. And it sort of closed down conversations about how to take care of themselves and how to enhance their wellness outside of getting tested, receiving contraception, getting sexual health materials and sexual health education materials. And they really emphasize that the most sort of important way to address that is a sex-positive approach to care, especially because a sex-positive approach to care begins to combat some of the stigmas around whether it's okay for these youth to be engaging in sex or thinking about sex at all. I'll talk a little bit about sort of what our youth say wellness looks like to them and what that as a model for health as a converse to risk assessment might look like. So for our youth, they really emphasize that wellness is both individual and it's holistic. So we're working with youth that have multiple complex and intersecting identities. They're not just gay, they're not just transgender, they're not just bisexual. They have a lot of different needs that come from different parts of their identity, and they had this feeling that there's sort of a one-size-fits-all approach to sexual health care, and especially once they came out, they felt like the scripts that were given to them were often stigmatizing or heteronormative. If you walk into a doctor's office and they say, when's the last time you have sex with a man? And you say, I've never had sex with a man, sometimes the conversation's over then, even when you might be having different kinds of sex and when you might need information about that. And the scripts that providers use in the exam room sort of shut down those conversations. Wellness also just looks different for everyone. Youth emphasized that they really wanted to be seen as the experts on their own health, their own needs, their own experiences. They didn't want to be questioned when they asked for things in clinical experiences. If they asked for contraception, even though they reported not having sex with people who had penises, they didn't want to be asked, why is that? It's sort of this underlying idea that the youth are the experts on their own bodies. If they're asking you for something, it's because they want it and they know why they need it. And there shouldn't be sort of an interrogation process, which can ultimately lead to more stigmatizing experiences and more sort of mistrust with your provider, with sort of medical institutions generally. Moreover, they really emphasize that wellness is on a continuum rather than a binary. Wellness as an idea has really rose up in the public health world, but they sort of express this idea that it's treated as dichotomous and sort of as a proxy for health anyways. It's, are you physically or mentally ill or not? If you are, that's wellness. Or if you are, then that's not wellness. If you aren't, that is wellness, right? And that's not true. Like, there are several different aspects of your life. There's employment, there's family, there's relationship health, there's sexual health, there's mental health, emotional health, physical health. All of these different aspects can be at different levels of sort of priority, can be at different levels. You can have different quality of that different aspect of your health at different times, and it impacts your wellness in different ways. They wanted to be treated as whole people that might have intersecting identities that might be more important to them than their sexuality at different points. There's this idea that especially when it comes to mental health, that the experiences that youth have are very minimized. So especially in clinical experiences or in experiences with social workers or other sort of pseudo-providers that they encounter in their lives, that bullying, teasing, and other sort of stigmatizing interactions having to do with their sexuality can be constituted as normal conflict or bullying, and that the impact that those have on their mental health isn't taken seriously, and it makes it a lot more difficult for youth to conceptualize their experiences as like real, as traumatizing, which they a lot of times are. So yeah, I guess I can finish up talking a little bit about what our youth told us that they needed from the adults and the providers in their lives to really begin enhancing their own wellness. And I think first and most importantly is a willingness to listen. So they really expressed a sympathy and an understanding for the adults in their lives who might not agree with their sexuality or who are still working to understand what that means to them. But they wanted like healthy, comfortable, accepting, and affirming interactions. They wanted a willingness to listen, a willingness to go out of their way to learn new language, to learn about identities, to use folks' right pronouns, to not use minimizing language around sexuality or gender. And they also really express this interesting idea of wanting education for parents on emotional literacy and on how to best support their children. And yeah, so as far as like what they need from their healthcare providers, I think a lot of it comes down to quality of care. These are youth that might be hypersensitive to feeling like a burden, and they might have experienced family rejection. There are a lot of different challenges that make them question themselves in experience or in any encounters with adults, especially in formal settings like an exam room. And they emphasize that they just want a doctor that will look at them, that will talk to them, that will let them take the lead, talking about their needs, that when they walk into the exam room, the script isn't, what's wrong today? Are you sick? What do I need to give you? That's more reciprocal. And basically focusing a lot on the necessity of building rapport with your patients, with having a sense of cultural humility where you might not understand the needs that patients are expressing to you, but you have to honor them anyways and go out of your way to learn more about why those needs exist and how you can best serve them. They also, and this is an important thing to note, sort of because youth are often reliant on their parents for health insurance, for access to doctors, oftentimes your family decides your provider for you. There's a lot of concerns around confidentiality, even when, we know some confidentiality laws exist where some things can't be disclosed to your parents, that doesn't eliminate the fear and anxiety that exists around clinical encounters for these youth, where they're afraid that what happens in the exam room will somehow get back to their parents, or might get back to social workers, might get back to CPS, who these youth might have had traumatizing experiences with before. There's also a lot of experiences in the groups around where providers did disclose things to parents when they weren't supposed to, when they let parents in the room without asking the youth, where things could be, or where it could be revealed what kind of services youth sought through insurance services. And I think we need to think a lot more about how we can enhance confidentiality around clinical encounters so that youth feel empowered to ask for what they need and to be earnest and honest about themselves. Yeah, I think also importantly, they want providers to be knowledgeable and proactive in sort of providing information. So it's a really important balance between being didactic and preachy and giving important information related to risk. So a lot of our youth express that knowing what STI prevalence looked like among folks that look like them was very important to them, but they don't want to be treated like they're high risk. They don't want to be treated like a burden because of the sexual behaviors that they are sharing in the exam room. But yeah, I think a lot of this speaks to yeah, we're good. Okay. Oh no, it's okay. No. Yeah, I don't really have a final statement. Y'all can roll with that. I think I lost a battery. I'm sorry.
Thank you, Mr. Smith, for that very nice presentation. I'm going to now introduce Dr. Struthers Van Horne. She's going to be presenting her research on the influence of structural stigma on mental illness, state-level structural stigma, and quality of life and attitudes towards treatment seeking. I'll figure out what.
All right. So this research is based on my dissertation, and before I get started, I just want to say thank you again to everyone here for all of the work that you do, and also for the people putting on the conference. This is fantastic. So in 2018, an estimated 47.6 million adult Americans lived with some form of mental illness. If we think about that, that's over 19% of the population who has some form of mental illness. And as we know, a diagnosis of mental illness is associated with a significant amount of stigma. And research has shown a wide variety of different negative social and health-related consequences. This ranges from everything from income loss, unemployment, all the way to poor quality of life and worsened mental health outcomes. And so one of the reasons that I have been so focused on studying stigma throughout my academic career is we know that despite the best efforts from researchers and from policymakers to undermine negative perceptions of mental illness and help eliminate and eradicate stigmatization, attitudes about mental illness have not changed since the 1950s when we first started measuring some of these attitudes. Overwhelmingly, perceptions are related to depictions of violence and criminalization. And so those attitudes have just not changed. And so part of my research is trying to look at ways that we can expand areas to target stigma reduction. And so while the literature on stigma is expansive, the bulk of it has focused on public attitudes towards mental illness or cultural stigma, and also looking at more personal stigma measures, such as experience discrimination. But one area that does remain understudied is structural stigma. And so you can't really read it, but this definition that I have here, this actually wasn't put forth until 2014. So structural stigma is a relatively new concept. It's been studied more in public health, but part of my research goals are to look at how structural stigma influences people with mental illness. And so if we think about structural stigma, we can think of it more towards macro level policies and factors. So institutional policies and societal conditions And they're important to consider as they impact not only our cultural perceptions of mental illness, but ultimately the experience of the stigmatized identity. And so as I mentioned to date, mental health literature has done very little to kind of integrate structural stigma into the broader stigma literature. So great. So I know this is a little hard to read, but this is my full model that I did for my dissertation. And I wanted to show this not only to show everyone a little bit of the different types of measures that I was looking at by trying to incorporate structural stigma, but also because I wanted to show you kind of how I've laid out how different factors of stigma can influence each other. And so I had two broad main goals with my dissertation. And, sorry, can you go back? Sorry, thank you. And so the first one was to incorporate structural stigma into the mental health literature. And what I did is I created a web panel survey, and I also created my own measure from outside constructs of structural stigma. And I looked at two important outcomes for people who self-reported having a mental illness, and that is perceived quality of life and attitudes towards seeking treatment. And one of the more important contributions, I think, of my research is the fact that when I developed structural stigma measures, I tried to make sure to incorporate a multifaceted measure of structural stigma from outside sources. And so I looked at three distinct kind of components. I looked at healthcare policy, and in looking at healthcare policy, I was able to look at state mental health expenditure per capita. I was also able to look at mental health parity. Each state has either full, partial, or no parity between mental health coverage and physical coverage. I also had a media measure looking at donated time for anti-stigma campaigns. And then finally, I also was able to look at restrictive legislation. So every state has between 0 and 5 civil liberties that are civil rights that are restricted against people with mental illness. And that is the right to be in a jury, the right to hold office. It also can be used for grounds for marital dissolution and parental rights. And so what I did is I measured these things at the state level and tried to see how structural stigma impacted both cultural and personal stigma measures, but also the outcome on individual outcomes for people with mental illness. We go to the next slide. And so I just wanted to briefly show kind of some of my key findings. This is kind of a first preliminary look at how we can try to incorporate some more structural factors in the stigma conversation. And in terms of structural stigma and well-being for people with mental illness, I found that individuals who are residing in states with higher levels of structural stigma, they had self-reported lower quality of life. So this is showing some promising results for how structural factors can impact individual level outcomes. I did conduct a secondary analysis to try to see if there was any of the specific structural measures that were driving these results. And I found that restrictive legislation was the most influential structural stigma measure examined in this study. So for people who are residing in states with more restrictions on their civil rights, they were more likely to have self-reported well-being. And then finally, in connecting structural stigma to cultural stigma, higher levels of structural stigma were associated with more negative attitudes towards the treatment of the mentally ill in communities. So again, this is some new integrating research to try to integrate more structural measures and ultimately to try to find other ways that we can start to target stigma reduction. And so I think this is promising, is another avenue to try to consider when we're conceptualizing stigma, and hopefully more research in this area will continue. Thank you.
So thank you, Mr. Smith and Dr. Van Horne, for your great presentations. Since we are a bit over, I'm going to encourage you all to please come to the poster session at lunch, because both of our speakers will be presenting posters there, as well as our other abstracts that were accepted. So thank you if you can join me in thanking both speakers.